the spinal cord, peripheral nervous system, and autonomic nervous system. Good morning. Today we'll explore three crucial components of the nervous system: the spinal cord, the peripheral nervous system, and the autonomic nervous system. This comprehensive overview will help you understand how these systems work together to maintain bodily functions and respond to our environment. Let's begin with the fundamental structure that serves as our body's major communication highway, the spinal cord. Protected by the vertebral column, consisting of 33 vertebrae, the spinal cord passes through an opening called the vertebral foramen. This vital structure is wrapped in three protective layers called meninges: the tough outer dura mater, the web-like arachnoid mater, and the innermost pia mater. Between the arachnoid and pia mater lies the subarachnoid space, which contains cerebrospinal fluid, crucial for protecting and nourishing the nervous system. The spinal cord contains 30 segments, corresponding to 30 pairs of spinal nerves that exit through openings called intervertebral foramen. At its lower end, the spinal cord forms a structure called the cauda equina, a bundle of lumbar and sacral nerves resembling a horse's tail, which controls motor and sensory functions of the lower body and pelvic organs. In cross-section, the spinal cord reveals a butterfly-shaped area of gray matter surrounded by white matter. The gray matter contains distinct regions called horns. Ventral horns house motor neurons controlling skeletal muscles, lateral horns contain autonomic neurons serving internal organs, and dorsal horns process incoming sensory information. The white matter contains various tracts, or bundles of axons, that carry information up and down the spinal cord. Ascending tracts transmit sensory information to the brain, while descending tracts carry motor commands from the brain. Key tracts include the dorsal columns, carry conscious proprioception, vibration sensing, and discriminative touch from skin, muscles, tendons, and joints to the primary somatosensory cortex. The lateral spinothalamic tract transmits pain and temperature sensations. The anterior spinothalamic tract handles pressure, texture, and light touch. The spinocerebellar tract sends unconscious proprioceptive information to the cerebellum for coordination and balance. For motor control, the spinal cord contains both upper and lower motor neurons. Upper motor neurons run in descending tracts from the brain, while lower motor neurons originate in the ventral horns and directly innervate muscles. The largest motor pathway is the corticospinal tract, which primarily controls voluntary movement. Specific motor pathways include the lateral corticospinal tract, originates in the primary motor cortex and decussates, crosses, at the medulla oblongata to the contralateral side of the spinal cord. The anterior corticospinal tract also originates in the primary motor cortex, with about 10% of axons not decussating, controlling trunk and neck muscles for posture and gross movements. The reticulospinal tract originates in the reticular formation of the brainstem, controls rhythmic gait patterns and autonomic functions, and doesn't decussate. The vestibulospinal tract originates in vestibular nuclei of the brainstem, receives input from the inner ear and cerebellum for equilibrium, and controls proximal limb muscles for balance and posture. Spinal cord injuries, SCIs, represent a significant medical challenge, with motor vehicle accidents being the leading cause. These injuries can be classified in several ways: by the number of limbs affected, the segmental level of injury, the bony level of injury, and the functional level. A critical distinction is made between complete and incomplete SCIs. Complete injuries result in total paralysis and sensory loss below the injury, while incomplete injuries retain some motor or sensory function. The presence of sacral sparing, functioning of the S5 nerve root, is a crucial prognostic indicator. Immediately following an SCI, patients enter a condition called spinal shock, where all reflexes below the lesion are temporarily shut down, typically affecting bladder and bowel control. Physicians assess injury extent through dermatome testing, checking sensation in skin areas served by specific spinal nerves, and motor function testing. An interesting aspect of SCIs is how paralysis differs at versus below the lesion level. At the lesion site, muscles experience flaccid paralysis due to lower motor neuron damage, resulting in hypotonic muscles. Below the lesion, upper motor neuron damage leads to spastic paralysis with hypertonic muscles and intense contractions. A positive Babinski sign indicates an upper motor neuron injury. Secondary complications of SCIs can be severe, including pressure sores, heterotopic ossification, abnormal bone growth, decreased bone density, autonomic dysreflexia, a potentially fatal uncontrolled autonomic response, spasticity, sometimes accompanied by clonus, rapid, rhythmic muscle contractions, central cord syndrome, specifically affecting upper extremity muscles, spondylosis, stenosis in the cervical region. The peripheral nervous system, PNS, consists of 30 pairs of functional spinal nerves, 8 cervical, 12 thoracic, 5 lumbar, and 5 sacral. Unlike the central nervous system, the PNS can regenerate to some extent. Spinal nerves are considered mixed because they contain both sensory, afferent, and motor, efferent fibers, including somatic and autonomic components. These relatively short nerves, measuring 1 to 2 centimeters, divide into dorsal rami, which serve posterior body structures, and ventral rami, which serve anterior structures and form nerve plexuses. The nerve structure is safeguarded by 3 protective layers: the endoneurium, a delicate layer surrounding individual axons, the perineurium, which bundles axons into fascicles, and the epineurium, which serves as a tough outer protective layer. The ventral rami form 4 major plexuses. The cervical plexus includes the ansa cervicalis, which controls swallowing and speech muscles, and contains the phrenic nerve that innervates the diaphragm for breathing and controls hiccups through phrenic nerve irritation. The brachial plexus features a complex organization from roots to named nerves, known as arm. The ulnar nerve controls hand grip and sensation. The median nerve handles most finger movements and thumb control. The axillary nerve moves the shoulder. The radial nerve extends the arm and wrist, and the musculocutaneous nerve flexes the arm. Additional important nerves include the dorsal scapular nerve, which innervates rhomboids and levator scapula, the suprascapular nerve, which innervates supraspinatus and infraspinatus, and the subscapular nerve, which innervates subscapularis and teres major. The lumbar plexus contains several significant nerves: the femoral nerve, which is the largest in the plexus, the iliohypogastric nerve, which serves abdominal muscles and provides sensation to gluteal and pubic regions, the ilioinguinal nerve, which handles sensation in the genital area, and the genitofemoral nerve, which controls the cremaster muscle and provides genital sensation. The sacral plexus contains the sciatic nerve, which is the largest nerve in the body with a 2 centimeters diameter, divides into tibial and common peroneal nerves, and controls hamstrings while providing leg and foot sensation. The peripheral nervous system can be affected by various conditions and injuries that impact daily function and quality of life. One common condition is carpal tunnel syndrome, which occurs when the median nerve becomes compressed as it passes through the carpal tunnel in the wrist. This compression typically results in numbness, tingling, and weakness in the hand and fingers, particularly affecting the thumb, index, and middle fingers. If left untreated, it can lead to a condition known as ape hand, where the thumb muscles become weakened and atrophied, limiting opposition and grip strength. Ulnar nerve injury presents with a characteristic deformity called claw hand, where the 4th and 5th fingers become hyperextended at the metacarpophalangeal joints and flexed at the interphalangeal joints. This occurs because the ulnar nerve controls many of the small muscles in the hand that maintain proper finger positioning. The ulnar nerve is also responsible for the familiar funny bone sensation when struck at the elbow, as it passes close to the surface near the medial epicondyle of the humerus, making it vulnerable to compression and trauma. Radial nerve injury results in wrist drop, a condition where patients cannot extend their wrist and fingers due to weakness in the extensor muscles. This commonly occurs from prolonged pressure on the radial nerve, such as from improper use of crutches, hence the term crutch paralysis, or from sleeping with the arm draped over a chair. Birth injuries can affect the brachial plexus, resulting in Erb's palsy. This condition typically occurs during difficult deliveries when excessive pulling on the infant's head and neck stretches or tears the upper brachial plexus nerves. The characteristic presentation is known as waiter's tip position, where the affected arm is internally rotated with the forearm extended and pronated and the wrist flexed. Sciatica represents another significant nerve condition, characterized by pain, numbness, or tingling that radiates along the path of the sciatic nerve from the lower back through the buttocks and down the leg. This condition most commonly results from herniated discs pressing on nerve roots, but can also occur due to piriformis syndrome, where the sciatic nerve becomes compressed by the piriformis muscle. Other contributing factors include degenerative disc disease, sedentary lifestyle, obesity, and improper lifting techniques. Neuropathy encompasses a broader spectrum of nerve disorders that can arise from various causes. Diabetic neuropathy, particularly concerning due to its prevalence, occurs when chronically elevated blood glucose levels damage peripheral nerves. This can lead to decreased sensation, particularly in the feet, which, combined with poor circulation and reduced healing capacity in diabetic patients, can result in serious complications, including amputation. Infections such as shingles and leprosy can also cause neuropathy, as can autoimmune conditions like Guillain-Barré syndrome, where the body's immune system attacks the peripheral nerves, leading to progressive weakness and potential paralysis. Early warning signs of nerve problems often present as paresthesia, abnormal sensations described as tingling, prickling, or pins and needles. These symptoms should not be ignored, as they may indicate the beginning of more serious nerve damage. Additionally, nerve compression can manifest through sharp or burning pain, numbness, and muscle weakness in the affected area. The specific pattern of symptoms often helps clinicians identify which nerves are involved and guide appropriate treatment strategies. Prevention and early intervention are crucial in managing nerve conditions. This may include ergonomic modifications, proper body mechanics, management of underlying conditions like diabetes, and appropriate protective measures during activities that could put nerves at risk of injury or compression. Understanding these conditions and their presentations is essential for healthcare providers to ensure proper diagnosis and treatment, ultimately working to preserve nerve function and patient quality of life. The white matter of the spinal cord contains specialized pathways that facilitate precise communication between the brain and body. These pathways, known as spinal tracts, serve distinct functions in carrying sensory and motor information. The ascending tracts, responsible for transmitting sensory information to the brain, include several specialized pathways. The dorsal columns serve as high-precision conduits for conscious proprioception, enabling our awareness of body position in space. These same columns also transmit vibration sensations and enable discriminative touch, allowing us to distinguish between different textures and perform complex tactile tasks. This information originates from various receptors located in the skin, muscles, tendons, and joints, ultimately reaching the primary somatosensory cortex, where it's processed into conscious awareness. Working alongside the dorsal columns, the lateral spinothalamic tract specializes in transmitting vital information about pain and temperature. This pathway proves crucial for protective responses and maintaining body temperature homeostasis. The anterior spinothalamic tract complements these functions by conveying sensations of pressure, texture, and light touch, adding another layer to our sophisticated sensory perception system. For movement coordination, the spinocerebellar tract plays a unique role by sending unconscious proprioceptive information to the cerebellum, enabling smooth, coordinated movements without conscious effort. The spinal cord's motor control system operates through a sophisticated network of upper and lower motor neurons. Upper motor neurons extend from the brain through descending tracts, while lower motor neurons, originating in the ventral horns, directly connect to and control muscles. The corticospinal tract stands as the primary motor pathway, with its lateral portion originating in the primary motor cortex and crossing, decussating, at the medulla oblongata to control the opposite side of the body. This crossing explains why brain injuries affect the contralateral side of the body. The anterior corticospinal tract, also originating in the primary motor cortex, maintains about 10% of its fibers uncrossed, specializing in controlling trunk and neck muscles for posture and broader movements. The reticulospinal tract, emerging from the brainstem's reticular formation, manages rhythmic movements like walking and contributes to autonomic function regulation. Unlike many other tracts, it maintains an ipsilateral course, never crossing to the opposite side. The vestibulospinal tract, originating in the brainstem's vestibular nuclei, receives critical input from the inner ear's balance organs and the cerebellum. This tract proves essential for maintaining equilibrium and controlling the proximal limb muscles that keep us balanced and properly positioned in space. Spinal cord injuries, SCIs, lead to a cascade of secondary complications that significantly impact patient health and quality of life. Pressure sores develop as a serious concern for immobilized patients, potentially leading to dangerous sepsis if infected. The body responds to injury with abnormal bone formation, known as heterotopic ossification, while simultaneously experiencing decreased bone density due to reduced weight-bearing and mobility. This combination creates a complex challenge for rehabilitation and long-term health management. Autonomic dysreflexia emerges as one of the most dangerous complications, presenting an uncontrolled autonomic response that can become life-threatening if not promptly addressed. Patients often develop spasticity, characterized by involuntary muscle contractions and increased muscle tone, which can significantly impact mobility and comfort. The condition frequently accompanies central cord syndrome, which specifically affects upper extremity muscle function. Additionally, patients may experience stenosis in the cervical region, known as spondylosis, further complicating their condition and treatment options. The impact on daily functions proves equally challenging, with patients experiencing various degrees of bowel and bladder dysfunction, sexual health issues, and potential mental health decline. These complications require comprehensive management strategies and ongoing medical supervision to maintain optimal health and prevent further complications. The peripheral nervous system's architecture demonstrates remarkable organizational complexity, with each nerve designed for optimal function and protection. These nerves, though relatively short at only 1 to 2 centimeters in length, contain sophisticated layered protection systems essential for maintaining proper signal transmission. The innermost layer, known as the endoneurium, consists of delicate connective tissue that carefully surrounds individual axons, providing them with a protective microenvironment crucial for proper signal conduction. Moving outward, the perineurium bundles these protected axons into functional units called fascicles, adding another layer of protection while organizing nerve fibers into efficient transmission pathways. The outermost layer, the epineurium, provides the final protective barrier with its tough, fibrous composition. This layer connects seamlessly with the spinal cord's dura mater, ensuring continuous protection throughout the nervous system. These nerves divide into specialized rami, each serving specific body regions. The dorsal rami extend posteriorly, innervating the back skin and muscles, while ventral rami course anteriorly to serve the body's front and sides, including the limbs. The ventral rami's organization proves particularly important as they form complex networks called plexuses, which enable sophisticated control of limb movement and sensation. The autonomic nervous system's chemical communication relies primarily on two key neurotransmitters, each playing distinct roles in neural signaling. Acetylcholine serves as the primary neurotransmitter for all preganglionic neurons throughout the autonomic nervous system, as well as for postganglionic parasympathetic neurons. This arrangement ensures precise control of parasympathetic functions associated with rest and digestion. In contrast, norepinephrine dominates sympathetic postganglionic transmission, facilitating quick responses during stress or emergency situations. These neurotransmitters interact with specific receptor types to produce their effects. Nicotinic receptors, found throughout the autonomic nervous system, consistently produce stimulatory responses, triggering immediate cellular responses through depolarization. Muscarinic receptors demonstrate more complex behavior, capable of either inhibitory or excitatory effects depending on the specific receptor subtype and its location. This versatility allows for fine-tuned control of various autonomic functions. Norepinephrine's effects vary based on the receptor type it encounters. When binding to alpha receptors, it triggers widespread vasoconstriction, effectively reducing blood flow to specific organs while increasing systemic blood pressure and blood glucose levels. Beta-1 receptor activation leads to renin release, contributing to blood pressure regulation, while beta-2 receptor stimulation enhances respiratory function and further modulates blood glucose levels. The autonomic nervous system's dual control creates a sophisticated balance through opposing effects on various organ systems. In the cardiovascular system, sympathetic stimulation increases both heart rate and contractile force, while parasympathetic influence decreases these parameters, allowing precise control of cardiac output based on body demands. Similarly, respiratory function shows this dual control, with sympathetic stimulation dilating airways to enhance oxygen intake, while parasympathetic effects constrict them during periods of rest. Digestive processes demonstrate particularly clear opposing effects. Sympathetic activation reduces digestive activity by decreasing blood flow and inhibiting digestive enzymes, prioritizing resources for emergency responses. Conversely, parasympathetic stimulation enhances digestive functions by increasing motility, relaxing sphincters, and promoting the release of digestive enzymes and juices. The pancreas exemplifies this dual control, with sympathetic stimulation promoting glucagon release, while inhibiting digestive enzyme secretion, and parasympathetic activation encouraging insulin release and digestive enzyme production. Visual adaptation also reflects this dual control, with sympathetic activation dilating pupils and adjusting the lens for distance vision, while parasympathetic effects constrict pupils and optimize the lens for near vision. Blood coagulation increases under sympathetic influence, preparing the body for potential injury, while parasympathetic control has minimal effect on this process. Salivary gland function varies between thick saliva production under sympathetic control and copious, watery saliva during parasympathetic activation. Reproductive organ response includes sympathetic constriction of reproductive ducts and parasympathetic vasodilation of erectile tissue. The hypothalamus orchestrates this complex interplay, maintaining appropriate balance between these opposing systems. This balance proves crucial for maintaining vasomotor tone, the partial constriction state of blood vessels that helps regulate blood pressure and flow. Understanding these opposing yet complementary effects helps explain both normal physiological responses and potential complications, such as autonomic dysreflexia in spinal cord injury patients. Autonomic dysreflexia represents one of the most serious and potentially life-threatening complications of spinal cord injury. This condition typically occurs in individuals with spinal cord injuries at or above the T6 level, though it can occasionally affect those with injuries as low as T8. Understanding this condition is crucial for healthcare providers and patients alike, as it constitutes a medical emergency requiring immediate intervention. The pathophysiology of autonomic dysreflexia involves a complex response to noxious stimuli below the level of injury. When such stimuli occur, such as a full bladder, constipation, or pressure sore, sensory signals travel upward through the spinal cord toward the brain. However, due to the spinal cord injury, these signals cannot reach the brain through normal pathways. Instead, they trigger a massive sympathetic response below the level of injury. This response manifests as severe vasoconstriction below the injury level, profound sweating above the level of injury, pilomotor reflex, goosebumps above the injury level, severe hypertension due to widespread vasoconstriction, and bradycardia as the body attempts to compensate for the hypertension. Various situations can precipitate an episode of autonomic dysreflexia. Bladder distension serves as the most common trigger, but other precipitating factors include bowel distension or impaction, skin irritation or pressure sores, tight clothing or positioning devices, ingrown toenails, urinary tract infections, sexual activity, temperature extremes, menstrual cramping, and fractures or other injuries below the level of injury. The clinical presentation of autonomic dysreflexia typically includes a sudden onset severe headache, which serves as the cardinal symptom. Patients may also experience profuse sweating above the level of injury, flushing of the face, neck and shoulders, nasal congestion, blurred vision, and anxiety or a sense of impending doom. Severe hypertension, with blood pressure rising 20 to 40 millimeters of mercury above baseline, often occurs alongside bradycardia or reflexive slowing of heart rate. The skin below the level of injury may become cool and pale due to vasoconstriction. Immediate management of autonomic dysreflexia requires swift and focused intervention. Treatment begins with sitting the patient upright to utilize gravity to reduce blood pressure, followed by loosening or removing any tight clothing or devices. Healthcare providers must quickly identify and remove the triggering stimulus while monitoring vital signs frequently. If bladder distension is suspected, catheterization may be necessary. Similarly, digital stimulation might be required if bowel distension is the cause. Antihypertensive medications may be administered if blood pressure remains elevated despite these interventions. The long-term implications of untreated autonomic dysreflexia can be severe and potentially fatal. Complications may include seizures, retinal hemorrhage, pulmonary edema, myocardial infarction, cerebral hemorrhage, and death. Therefore, prevention plays a crucial role in managing this condition. Healthcare providers must educate patients and caregivers about regular bladder and bowel management programs, proper skin care and pressure relief techniques, and the importance of regular inspection of clothing and positioning devices. Patients should learn to recognize early warning signs and maintain proper documentation of their condition through medical alert identification. Healthcare providers play a vital role in managing autonomic dysreflexia. They must recognize it as a medical emergency requiring immediate intervention and understand the relationship between the level of injury and risk for this condition. Their responsibilities include implementing emergency protocols, educating patients, families, and caregivers about prevention and management, providing appropriate follow-up care and monitoring, developing individualized management plans, and coordinating care among various specialists involved in the patient's treatment. Living with the risk of autonomic dysreflexia significantly impacts daily life, requiring constant vigilance regarding potential triggers and regular medical monitoring. Patients must implement lifestyle modifications to prevent episodes and maintain emergency preparedness. A strong support system, understanding of the condition, regular communication with healthcare providers, and psychological support to manage anxiety about potential episodes all contribute to successful management of this condition. The significance of understanding autonomic dysreflexia cannot be overstated for anyone involved in the care of individuals with spinal cord injuries. Its sudden onset and potentially fatal consequences make it one of the most serious complications requiring immediate recognition and intervention. Through proper education, prevention strategies, and prompt treatment, the risks associated with this condition can be effectively managed, allowing individuals with spinal cord injuries to maintain a better quality of life while minimizing the risk of severe complications. The human body contains 31 pairs of functional spinal nerves, which can be broken down into 8 cervical, 12 thoracic, 5 lumbar, 5 sacral, and 1 coccygeal pair. Unlike the central nervous system, the peripheral nervous system, PNS, has the remarkable ability to regenerate to some extent, with Schwann cells playing a crucial role in guiding regenerating axons and providing trophic support. In terms of nerve anatomy, motor axons exit the spinal cord through ventral roots, while sensory PNS neuron cell bodies are located in structures called dorsal root ganglia, DRG. The autonomic nervous system, ANS neurons specifically innervate smooth muscle, cardiac muscle, and glands. ANS neuron cell bodies have specific locations within the spinal cord. Sympathetic neurons are found in the lateral horn from T1L2, while parasympathetic neurons are located in the brainstem and sacral region, S2-S4. Spinal nerves are classified as mixed nerves because they contain both sensory, afferent, and motor, efferent fibers, including both somatic and autonomic components. These spinal nerves are relatively short, typically measuring only 1 to 2 centimeters before they divide into ventral and dorsal rami. The dorsal rami are posterior branches that innervate the back muscles, skin of the back, and joints of the vertebral column. In contrast, ventral rami are anterior branches that innervate the limbs, anterior/lateral trunk muscles, and their associated skin regions. It is these ventral rami that form the important nerve plexuses. The connective tissue organization of nerves is complex and consists of 3 main layers. The endoneurium is the innermost layer, surrounding individual nerve fibers and containing collagen fibers and fibroblasts. The perineurium forms the middle layer, surrounding bundles of nerve fibers, fascicles, and forming the critical blood-nerve barrier. The epineurium is the outermost layer that surrounds the entire nerve and contains blood vessels and adipose tissue. There are 4 major nerve plexuses in the body: the cervical plexus, brachial plexus, lumbar plexus, and sacral plexus. Within the cervical plexus, the ansa cervicalis is responsible for innervating the infrahyoid muscles, which function to depress the hyoid bone during swallowing and speaking. The phrenic nerve, another important component of the cervical plexus, innervates the diaphragm and serves as the primary muscle of respiration. When the phrenic nerve is irritated, or when there is stomach distension or rapid eating/drinking, this can trigger hiccups, which are sudden involuntary contractions of the diaphragm. The brachial plexus has a complex organization where ventral rami converge to form trunks, which then divide into anterior and posterior divisions. These divisions form cords, which ultimately give rise to terminal branches or named nerves. This intricate arrangement of convergence and divergence serves several purposes. It allows for the coordination of complex movements, provides redundancy in innervation, and enables precise control of the upper limb. The major named nerves of the brachial plexus can be remembered using the acronym UMARM. The ulnar nerve provides motor function to intrinsic hand muscles and hypothenar muscles, while providing sensory innervation to the medial 1.5 digits and medial palm. The median nerve controls most forearm flexors and thenar muscles, with sensory distribution to the lateral palm and lateral 3.5 digits. The axillary nerve innervates the deltoid and teres minor muscles, with sensory distribution to the lateral shoulder region. The radial nerve controls the triceps and forearm extensors, providing sensory innervation to the posterior arm, forearm, and dorsal hand. The musculocutaneous nerve innervates the anterior arm muscles and provides sensory innervation to the lateral forearm. Additional important nerves in the upper limb include several specialized branches. The dorsal scapular nerve innervates the rhomboid muscles and levator scapulae. The suprascapular nerve provides innervation to the supraspinatus and infraspinatus muscles. The subscapular nerve supplies innervation to the subscapularis and teres major muscles. The thoracic ventral rami have a simpler distribution, innervating the intercostal muscles, abdominal wall muscles, and their associated skin. Moving to the lower limb, the femoral nerve stands as the largest nerve in the lumbar plexus. The iliohypogastric nerve provides motor function to abdominal muscles and sensory innervation to suprapubic and lateral hip regions. The ilioinguinal nerve supplies motor function to internal oblique and transversus abdominis, while providing sensory innervation to the inguinal region and proximal thigh. The genitofemoral nerve controls the cremaster muscle and provides sensory innervation to the anterior scrotum or labia and upper thigh. The lateral femoral cutaneous nerve provides sensory innervation to the lateral thigh. The femoral nerve supplies motor function to anterior thigh muscles and sensory innervation to the anterior thigh and medial leg. The saphenous nerve provides sensory innervation to the medial leg and foot. The obturator nerve controls the adductor muscles and provides sensory innervation to the medial thigh. The sciatic nerve is the largest nerve in the body, measuring approximately 2 centimeters in diameter. It divides into 2 major branches, the tibial nerve and common peroneal nerve. This large nerve provides motor function to the posterior thigh muscles and sensory innervation to the posterior thigh, most of the lower leg and foot. The pudendal nerve serves multiple functions within the body. It provides motor innervation to perineal muscles and external sphincters, sensory innervation to the perineum and external genitalia, and parasympathetic innervation to the genitalia. The superior gluteal nerve controls motor function of the gluteus medius, gluteus minimus, and tensor fasciae lati muscles. The inferior gluteal nerve specifically innervates the gluteus maximus muscle. The posterior femoral cutaneous nerve provides sensory innervation to the posterior thigh and popliteal fossa, while the piriformis nerve solely innervates the piriformis muscle. In the lower leg, several nerves provide specific functions. The tibial nerve controls motor function of posterior leg muscles and provides sensory innervation to the posterior leg and plantar foot. The superficial peroneal nerve innervates the lateral compartment muscles and provides sensory innervation to the dorsum of the foot. The deep peroneal nerve controls the anterior leg muscles and provides sensory innervation to the first web space. Regarding nerve fiber types, the type Ia proprioceptive fibers are the fastest in the body. Motor fibers are classified into 3 distinct types based on their characteristics. Alpha motor fibers are large and fast-conducting, innervating skeletal muscle. Beta motor fibers are medium-sized with moderate conduction speed and innervate muscle spindles. Gamma motor fibers are small and slow-conducting, also innervating muscle spindles. Several pathological conditions can affect peripheral nerves in various ways. Nerve compression occurs when pressure is applied to a nerve, resulting in numbness, pain, and weakness. If left untreated, this compression can lead to permanent damage. Sciatica manifests as pain along the sciatic nerve distribution, usually resulting from a herniated disc or piriformis syndrome. Piriformis syndrome specifically involves compression of the sciatic nerve by the piriformis muscle, leading to buttock and leg pain. Neuropathy encompasses damage to peripheral nerves and can affect motor, sensory, or autonomic function through multiple possible mechanisms. Paresthesia describes abnormal sensations such as tingling or numbness, which patients often describe as pins and needles. Guillain-Barré syndrome represents a serious condition involving autoimmune attack on peripheral nerves. This condition is often triggered by infection and causes ascending paralysis, which progresses from the lower extremities upward. Diabetic neuropathy presents as a significant complication of diabetes. This condition results from nerve damage caused by chronic high blood sugar levels. The neuropathy typically affects distal nerves first and causes a combination of numbness, pain, and autonomic dysfunction. One of the most serious outcomes of diabetic neuropathy is the development of diabetic foot ulcers. These ulcers occur due to the loss of protective sensation in the feet. Without proper treatment and management, these ulcers can lead to amputation of the affected limb, making early detection and intervention crucial for patient outcomes. Thank you for your attention on the spinal cord, peripheral nervous system, and autonomic nervous system. We hope the material was helpful in your journey into healthcare. Remember, the more you learn, the more you earn.